So after that fantastic theoretical overview, we can now do a deep dive into one of the disorders that is of great interest to the BNPA, which is Parkinson's disease. And it's a great pleasure to welcome Professor Stephane Thobois from Lyon. Stephane is a neurologist who has a special interest in using neuroimaging to unpick psychiatric complications of Parkinson's disease. So Stephane, bienvenue à Londres, and we look forward to your talk. Thank you.
So thank you very much for welcoming me at this very interesting meeting. I hope I will not spoil your day with my bad French accent first, and I apologize for this. So my talk will concern the impulse control disorders in Parkinson's disease, which is a major issue for us neurologists and psychiatrists. So I will deal with some mechanism aspects, clinical aspects, and then the treatment. So my disclosures. So as you all know, Parkinson's disease is characterized by a very large number of neuropsychiatric manifestations, going from depression, anxiety, apathy, to impulse control disorders, dopamine dysregulation syndrome, and pending. So it's a very heterogeneous disease in terms of neuropsychiatric manifestation. Looking at the impulse control disorders, many clinical aspects are very well known, and you all know all these things. There are four major types of impulse control disorders in Parkinson's disease: pathological gambling, compulsive shopping, binge eating, and hypersexuality. These are the four major categories of ICDs in PD. And this concerns at least 1/3 of our patients during their disease evolution. So it's a huge issue for us, and we have to take care of this issue very in depth. There are other types of ICDs that are less frequent or less looked at. I think they are very frequent, such as obesity, the compulsive internet use, hyperactivity, and especially nocturnal hyperactivity, and pending. And interestingly, in some of our patients, we can see a combination of ICDs and apathy. It's not, it seems to be contradictory, but in fact, we can see this association in around 10% of our patients if we look carefully at these patients. There are very well-known risk factors to develop ICDs in Parkinson's disease. The first one is the use of dopaminergic drugs, and especially dopamine agonists. They are the major risk factors of inducing ICDs in Parkinson's disease. But there are also some clinical aspects. So the early age at onset, the young age, being a male, single, having a history of addiction in the family, history of depression, and also the importance of non-motor fluctuations. And especially when you observe the patient with on-drug euphoria, or very severe neuropsychiatric fluctuations based on the treatment they receive, these patients are very high risk of developing a behavioral addiction and dopamine treatment addiction. So you can see which patients are at risk of developing ICDs. And importantly, there is a cumulative effect. So it's a long-term issue. And the more the patients take dopamine agonists, the greater the risk of developing ICDs in the long term. And beyond dopamine agonists, you have also to consider other drugs, such as MAO-B inhibitors, that can increase the risk of pathological gambling especially. This is a large Swedish study published last year pointing with the role of MAO-B inhibitors in pathological gambling. There is also a risk based on genetic risk factors, and these are the results of very large GWAS polymorphism studies. And these studies have shown that there are some polymorphism of dopaminergic D1, D2, D3, and now D4 receptors that can increase the risk of developing impulse control disorders in Parkinson's disease. You can also observe the risk based on polymorphism of serotoninergic receptors, and especially the 5-HT2A receptor. So we have genetic basis for developing ICDs. More recently, the ApoE4 polymorphism has also been associated with the risk of developing impulse control disorders. So what about the pathophysiology? It's only a very brief overview about the mechanism. And the first key player is the role of the dopaminergic system. The dopaminergic system, as you all know here, is deeply involved in the reward processes and the reward learning processes via the mesolimbic dopamine pathway and mesocortical dopamine pathway starting from the VTA. And the first thing we know very well from many studies is that at the presynaptic dopaminergic level of the synapse, you have a reduced density of dopamine transporter in the ventral striatum especially. And this can be observed before ICDs, so it's a risk factor, and also when ICDs are present. And the reduction of dopamine transporter, which role is to reuptake dopamine from the synapse and reduce the dopamine tonus in the synapse, will induce an increase of dopaminergic tonus in the synapse, and therefore a kind of overstimulation of the dopaminergic system. And we can also hypothesize that there may be a hypersensitivity, a compensatory hypersensitivity of the postsynaptic dopaminergic receptors, but this has not been proven yet. The question is this a trait or is this a state? We don't know yet, but importantly, this is very well correlated with the severity of behavioral addiction in Parkinson's disease. Looking at the hyperdopaminergic hypothesis, if we look at the dopamine synthesis and the activity of dopamine decarboxylase, you can observe using PET and fluorodopa that there is an increase of the uptake of this tracer in prefrontal regions, especially orbitofrontal regions, and this may lead, when patients receive dopaminergic drugs, to a hyperdopaminergic state and an overstimulation of the dopaminergic system. Looking at the dopamine D3 receptors, which are very interesting because they are mostly expressed in the mesolimbic and mesocortical dopaminergic pathways, using another tracer which is PHNO in the ventral striatum, which is part of a limbic cortical subcortical loop, you can observe a lower binding of this tracer in patients with ICDs, which can mean that there is an increased level of dopamine, endogenous dopamine, in these circuits. And again, this suggests a hyperdopaminergic activity in these mesolimbic pathways. And this, as you can see, is very well correlated with the severity of pathological gambling in this study. Interestingly, you can also use PET scan and raclopride to use at the dynamic of dopamine release in the synapse. So not only a static view of the synapse, but also how dopamine is released in the synapse when you take levodopa drug, for example. So raclopride is a dopamine D2, D3 receptor tracer that binds to these receptors, and the uptake of raclopride is inversely correlated with the amount of dopamine present in the synapse. So you can measure the release of dopamine using the displacement of raclopride in the synapse. And in dopamine dysregulation syndrome, which is a compulsive use of dopaminergic drugs in Parkinson's disease, Evans and his team have demonstrated 20 years ago that you have an increased, a major increase of dopamine release after a single dose of levodopa intake in the ventral striatum in patients with dopamine dysregulation syndrome in comparison to patients without dopamine dysregulation syndrome. So there is an abnormal sensitization of the dopaminergic system in dopamine dysregulation syndrome patients. And this will increase the want of the drug, but not the like of the drug. And you can observe the same mechanism in impulse control disorders, especially in pathological gambling. In many studies, when patients are exposed to an appetitive stimulus, and when they take levodopa, they will release a much larger amount of dopamine in the synapse, and they displace the raclopride in a much greater fashion than in patients without pathological gambling. So, and this is also correlated with the severity of pathological gambling. And when you look at the body cell and the release of dopamine at the level of the body cell and not at the synapse level, this is the opposite, and you have a reduced mesencephalic dopamine release when the patients are present impulse control disorders. And this is important because this will in turn increase the level of dopamine release in the synapse, because you have less inhibitory control of dopamine release in the synapse. So the dopaminergic system dysregulation is very well known. There are many, many, many publications, and this is very clear. But what about other neurotransmission systems? And one very interesting system is the serotoninergic system, because in the general population, as you all know, the dysfunction of the serotoninergic system is involved in pathological gambling, in drug addiction, in impulsivity, here again in pathological gambling. And there are very little studies having shown that serotonin reuptake inhibitors could improve pathological gambling. So what about Parkinson's disease? We recently published a paper looking at the serotoninergic system dysfunction in patients with and without impulse control disorders and in controls. We use a double-blind PET studies looking at the serotonin transporter using DASB and the 5-HT2A receptors using altancerine. And what we observed is that there are indeed dysfunction of the serotoninergic system in patients with impulse control disorders. First, you have an increase of the serotonin transporter level in the putamen and pallidum, especially on the left side. And furthermore, you have an alteration and an increase of altancerine binding, which could mean an increased availability of these 5-HT2A receptors. And this is very interesting because, as I said before, certain polymorphism of these receptors are associated with the risk of developing impulse control disorders. So it seems that the serotonin may also play a role beyond dopamine or in addition to dopamine in the development of impulse control disorders. This is interesting because the serotoninergic neurons are also involved in the metabolism of levodopa. When you give levodopa to your patients, these are the serotoninergic neurons that will transform levodopa into dopamine. There are many MRI studies that have also shown a dysfunction of an abnormal connectivity within and between different circuits in the brain. And this is one example of a study showing that there are a default of connectivity within the limbic circuitry and between the limbic and associative circuits in the brain of patients with pathological gambling. Another study showing an increased connectivity within the salience network and a decreased connectivity in inhibitory networks such as default mode network and central executive network. So it seems that there are an imbalance between the salience network and the inhibitory network that will contribute to the development of impulse control disorders in Parkinson's disease. And when you test, this is a gambling task in patients with and without impulse control disorders, the increased risk-taking in these patients is associated with a reduction of activation of the ventral striatum, which is a key player in the learning of the risk and the reward learning. and also a reduction of activation in the orbitofrontal and anterior cingulate cortex activation, which will induce a reduced aversion to the loss. And so this will perpetuate the abnormal behavior. And when you give a dopamine agonist to a patient, you will also observe a reduction of orbitofrontal activation, which will tend to, make the patient in incapacity to guide their behavior and to measure the negative outcome of their behavior. So what about the management? The management is a very difficult issue because there are no consensus of the way to treat these abnormal behaviors in our patients. There are some obvious things, which is to prevent and to trace regularly during outpatient clinic and visit the onset of impulse control disorders. Because early detection is the best way to treat these impulse control disorders and avoid very deleterious manifestation for the patient and his family. The first way is to reduce or stop dopamine agonist, but not in a too rapid fashion, because if you do so, you will induce a dopamine withdrawal disorder, which may be also very severe. Do not change from one agonist to another, this is a class effect side effect, so it will not change anything. Regarding quetiapine and clozapine use, there are very few level of evidence concerning their efficacy, and in my experience, I don't see that this is very efficient to reduce impulse control disorders. And I said before, the risk of dopamine withdrawal syndrome is major. It's a risk that may affect 1/4 of our patients, and it is characterized by a worsening of motor symptoms, anxiety, depression, pain, and sometimes suicide. So we have to be very careful about this risk when you reduce dopamine agonist or suppress dopamine agonist. This can be seen whatever the dopamine agonist is used. There is no improvement with levodopa, which is important to know. And it is not related to the previous dose of dopamine agonist. And the full recovery may take less than 6 months in 2/3 of our patients, but sometimes more than 1 year in 1/4 of our patients. So it's a long-lasting phenomenon, and it may be difficult to treat. And in some patients, around 15% of our patients, it is impossible to suppress dopamine agonists completely, which is a major issue. What about the impact of continuous dopaminergic treatment, such as levodopa gel, intestinal gel? It may reduce the incidence of impulse control disorders in comparison to oral levodopa. But there are few studies on this subject. Deep brain stimulation is a very efficient treatment to reduce impulse control disorders. This has been demonstrated in many studies, large studies, and you can see here in orange the preoperative impulse control disorders, and in purple the postoperative one. The issue here is that you will go from an appetitive functioning before surgery to an apathetic functioning after surgery in some patients. So it's a question of balance, and we know this now, and we have to monitor carefully the dopamine agonist drug after surgery to avoid apathy after surgery. It's important also to note that binge eating is not, we can arise after surgery and is usually not improved after surgery in comparison to other types of impulse control disorders. And also de novo impulse control disorders may arise after surgery. It's not so rare, and so it's patient dependent. But in the vast majority of the case, it's a good indication to propose surgery to this kind of patients, and it will improve their impulse control disorders. What about other approach and the noradrenergic approach? There are some studies having shown that increasing the tonus of the noradrenaline using atomoxetine, which is a noradrenaline transporter inhibitor, can improve motor inhibition in Parkinson's disease. So we decided to test the efficacy of clonidine. Clonidine is an alpha-2 noradrenergic drug that can increase the level of noradrenaline depending on the dose you use. And so we tested this in a phase 2 preliminary study in patients with impulse control disorders. This is a red line, and we observed on the QIP-RS score that there was a decrease in the severity of impulse control disorders, but in comparison to placebo, this did not reach statistical significance. Maybe the follow-up was too short, 8 weeks only. Maybe the primary endpoint was not the best, it was very restrictive. But importantly, there was also a very strong placebo effect. And what we call placebo effect, I think it's important to have this in mind, is not only a placebo effect. It was the regular following of these patients with neuropsychologists, psychologists, neurologists, and this led to a clear improvement of impulse control disorder. So it's not only a so-called placebo effect, it's a more interesting global approach. But we intend to conduct a larger phase 2 study to see if, or if not, the clonidine is efficient on impulse control disorders. And beyond the drugs, there are some studies on the cognitive and behavioral therapy that have proven some efficacy in impulse control disorders in Parkinson's disease. And a very elegant approach has been promoted by our colleague from Spain and the group of Ignacio Obeso, showing that if you modulate the pre-SMA activity with an excitatory RTMS on the pre-SMA, you can improve inhibition of the patients when they are facing erotic stimuli in this hypersexual patients. So modulating the circuits using RTMS could also be an interesting approach, and based on the physiology of this disorder. I would like to mention this excellent expert and consensus paper published last year in Movement Disorders, dealing with all the management and prevention of impulse control disorders. I think it's a very interesting paper. And to conclude, I would say that it's a major issue in our practice and for our patients. It may have major consequences for our patients, their family, but also the society. And there are some legal issues here. We have to keep this in mind. So early detection, prevent, inform the patient and their family of the risk, and monitor the risk at every outpatient visit is mandatory. There is also a need for a better understanding of the mechanism to provide new therapeutic approaches beyond the dopaminergic system regulation. I mentioned serotonin, noradrenaline, but maybe others. And in France, a large study has been finished last year, which is a PIMPARC study testing the efficacy of pimavanserin, which is usually used for dopaminergic psychosis and hallucination in Parkinson's disease. And so we have just finished with studies testing the efficacy of pimavanserin on impulse control disorders, and we'll see if it works or not. It could be a hope for our patients. And new approaches, non-drug approaches may be also interesting, but they need to be developed because, at least in France, the availability of cognitive and behavioral therapy is very low, and it's difficult to propose this kind of approach for a large number of patients. So thank you for your attention.
Yeah, thank you for a wonderful talk, Stephane. So a question from the online audience. We've got about 70 people online who are with us. So are there any studies assessing the potential of improving cholinergic transmission in frontal regions with acetylcholine esterase inhibitors and the impact of that system on impulse control disorders?
I think, as I know, there are no studies on the cholinergic system intervention on impulse control disorders. I'm not aware of imaging studies on the role. There is a role of the cholinergic system to treat apathy, but for impulse control disorder, I'm not aware of this kind of studies.
Okay. Do you think it potentially would be of value, or theoretically?
It can be tested, but I would like much more to go on with serotonergic approaches. I think it would be probably more efficient and yes.
Okay, thank you. Time maybe for one question or two questions from the audience. Romy. Wait for the mic, it's just coming.
Thank you for an excellent talk. It's trying to the balance between someone with ICDs and not turning them into someone with DAWs. So if you reduce the dose of the agonist and they say the ICDs are better, would you keep them on the lower dose, or would your aim be to get them off it completely? And not all the agonists are the same. They have different profiles on the D1 to D4 receptors. And if you've got someone with DAWs, 6 to 12 months is a long time. Would you offer them a switch, for example, if they were on pramipexole and they developed ICDs, to give them low-dose praticotine to manage the DAWs?
First, I think that reducing the dose may be enough in some patients. So the objective is not always to stop completely the drug, because there is a higher risk to develop dopamine withdrawal syndrome. So in my experience, I try first to reduce the dose. I also try not to, it's also important not to combine two dopamine agonists, which is unfortunately sometimes do by some of our colleagues. And, but I don't think that switching from one agonist to another is a good option, because the pharmacological profile is always D2, sometimes D2, D3, and so I don't think it's a good option to switch from example, ropinirole to pramipexole or rotigotine. The risk is the same, but just trying to reduce the dose may be enough in some patients, and it will reduce the risk of dopamine withdrawal syndrome.
Okay, time for one more question. Any gentleman here at the front?
I was just wondering if there's any thoughts on why there's a reduced ICD risk with more continuous dopaminergic stimulation, like with, as you alluded to in your slides, with gel or with rotigotine patch, compared to kind of more pulsatile dopaminergic stimulation with oral dopamine agonists?
I think that there is, this levodopa gel is for levodopa. So it's using levodopa gel will give you a continuous stimulation with levodopa, in opposition to the classic oral levodopa intake, which will give you pulses of dopamine release. So this concerns dopamine and levodopa, not dopamine agonist. And I don't think that there is a lower risk of developing ICDs using rotigotine patch in comparison to pramipexole or ropinirole. This was about levodopa, because a pulsatile levodopa intake may also increase the risk of developing impulse control disorder. So if you block this pulsatile administration with a continuous gel, you will reduce, at least in this study, there are very little evidence at the moment. So we have to check, and for example, with the new subcutaneous levodopa pump, we will see if there is a decrease in the occurrence of ICDs. But the key player is dopamine agonist, is not levodopa.
I think we'll have to stop there. Thank you, Stephane, for a wonderful session. So we've got time for a relatively short break. Grab a coffee, grab a snack, and we'll resume at 10:35. Thank you.